a restrictive disease.
I'm sorry.
So, yes,
I'm sorry, what page are you on?
120.
Thank you.
So asthma looks the same as cystic fibrosis as COPD. That's why you have to do the history and physical. You have to do spirometry before and after bronchodilators to find out whether or not someone has reversibility. It might tell you a little bit about whether or not in the situation of the age of the individual and the presence of their allergen stimulants, whether it's more likely that the etiology of the symptoms are related to asthma versus COPD. To make certain you're no surgical risk, to evaluate you for eligibility for SSI disability. But most importantly for asthma, it allows us to see the variability of the disease, not the progression. For COPD, it's progression, but for asthma, it's variability. So the EPR3 says that everyone needs to have asthma confirmed by spirometry. And then once you've confirmed asthma by spirometry, then you repeat it no less often than every 1 to 2 years. Well, remember, asthma is variable, so just because your spirometry is normal one time doesn't mean that you can rule out asthma. In fact, to confirm the diagnosis of asthma, you might have to wait till someone has a cold, has an allergy season, or you might actually have to send them for bronchoprovocation testing, because maybe the only way you can confirm they have asthma is by provoking it under laboratory conditions. So you confirm it, and then you do it every 1 to 6 months, but no less often than every 1 to 2 years. So for spirometry specific to asthma, you're going to do your pulmonary function test before and after you've given an albuterol in anyone 4 years of age or older. And you should be comparing your results compared to reference ranges of people who are the same age, race, height, non-smokers who don't have asthma. And we'll talk a little bit more about what all these values mean and the different population references. You can expect you're not going to get a good test result if individuals are in pain, especially oral pain where they can't hold the mouthpiece correctly. If a woman is concerned that her leaky bladder, I mean, it's a maneuver that causes a lot of intra-abdominal, intrathoracic, interocular, intracranial pressure increases. So that's an expectation. If there's any reason they can't follow commands because of autism, developmental delays, dementia, or young age. The only absolute contraindication is don't do this within a month of a heart attack. Because like I said, it's going to put so much increased pressure in your thoracic cavity, you're going to have decreased blood flow to the heart. You do not want to extend an infarction by doing pulmonary function tests. The relative contraindications, if you cough in the first second of the maneuver, you can't interpret spirometry. The other relative contraindications is because it increases pressure in your eyes, you could actually cause sutures from recent cataract surgery to be undone. If someone had an abdominal surgery, they could dehiss and kind of spill their guts out on top of your spirometer. You know, any of these things.
There's a day.
That's like not a good day. So these are all things to consider as relative contraindications. Now remember, spirometry is the only way you confirm the diagnosis, and peak flow monitoring is only used for monitoring. And that's because with peak flow meters, you can't quality assure whether you got good effort. You can overperform and underperform using a peak flow meter. You cannot under or overperform on spirometry without being able to see it on the tracing. If someone doesn't give you good effort, you can see it, and you can't overperform. But you know, on a peak flow meter, if you spit or do a tongue thrust into the peak flow meter, readings are artificially high. You can't do that on spirometry. On peak flow meters, if you underperform, you're going to see a tracing that shows you poor effort. You can't do that with peak flow meters. You also can't calibrate peak flow meters, and you get no printout. There's two primary ways that we look at the output from spirometry, and far and away, we use the bottom flow volume curves or loops. So that's what I'm going to show you today. In Europe, they tend to use a combination of these curves, loops, and the volume time curves. So I'll show you what I mean in a minute, but what you want to have for quality assurance and for reimbursement is that you need, in order to bill for spirometry in your office, you need to have a printout that shows the actual flow volume curve or loop, as well as the exhalation time, and you have to keep a calibration log. If you don't do those things, then you might be audited and found to be not in compliance for what needs to happen. So this is a flow volume loop. I use the analogy of a sailboat. You have the upward mast and the downward sloping sail. You have the water line, and then you have the rounded hull of the ship. So if you keep thinking about this as a sailboat and a water analogy, when you are underneath the water, you're holding your breath in. This is inhalation. What happens when you break the surface? You exhale. Everything above the waterline is exhalation. So that's an easy way to remember what part of the loop is inhalation underneath this waterline. What's exhalation? Everything above it. So we care in asthma about exhalation. Asthma is an obstructive disease. So we care about what's happening up here. Other diseases that happen in the lung, like sarcoidosis or pulmonary fibrosis, can also be found on the exhalation side. On the inhalation side, you're thinking about things that are happening outside of the lungs. You have some kind of tumor obstructing your large trachea, like a goiter or a cancer. It's happening. The only problem outside, or even vocal cord dysfunction, right? You get a flattening of the boat, okay? So we're not going to spend any time looking at inhalation. We're going to be spending our time looking at exhalation. And here is some examples of airway obstruction. It looks like a sailboat, but very small, which is telling us that there might be some quite severity, because the sailboat now looks like a shark fin, okay? And scooping out, we'll talk about that. This is what the volume time curve would look like. Restrictive disorders kind of have that sailboat shape, but they're smaller. So my brother has sarcoid, so his loop would look like that on the left. You also care about reproducibility, meaning that you want people to be giving you the best effort. So I don't know if you can tell, but this person did 3 maneuvers in blue, black, and green. And because it's so hard to tell the different colors, because they're giving you perfect effort every time, which you can see on the output. And all values are either volume, how much, or flow, how fast. So before I start getting into the nitty-gritty of the different parts, any questions? You understand the basic shape and idea of it, right? All right, so there are 3 things you care about to look at in spirometry: the FVC, the FEV1, and the ratio, which compares the FEV1, or actually divides it by the FVC. So what do they mean, and what's normal? The forced vital capacity is maximum exhalation after maximum inhalation. Forced vital capacity is maximum exhalation after maximum inhalation. And for everyone in the world, normal is greater than or equal to 80%. If someone can't exhale all of the way, then if they are a child under the age of 10, you get them to breathe out for at least 3 seconds. If they're an adult, they need to blow out for at least 6 seconds. But people who have obstructive diseases usually can blow out 8, 10, 12 seconds. So remember that. The forced expiratory volume is how much comes out in the first 1 second of exhalation. Forced expiratory volume in the first second, FEV1, is how much of the entire exhalation comes out in the first second. And 80% of your entire breath out should come out in the first second if your asthma is under control. So for everyone in the world, normal is greater than or equal to 80%. Then what you want to do is, how much did you get out in the first second compared to the entire breath out? That's called the ratio, the percent FVC, or the FEV1 over the FVC. How much did you get out in the first second compared to the entire exhalation? That's the ratio, percent FVC, or FEV1 over FVC, and that's the only one where normal is age dependent. So here we have a diagram. You can see the sailboat shape, and what you are looking at here, the only thing that you can estimate by looking at a graphic is the FVC, which is along the waterline from the beginning of the mast. You exhale, 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 blow, 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 blow. So from the beginning of the mast to the bottom of the sloping sail is the entire FVC along that water line. The FEV1, many spirometers, including mine, doesn't record it. Some have a spike, which shows you where in this downward sloping sail, it's usually right about here, you blow out 80% of this entire maneuver in about the first second. So you want no coughing in the area till all the way down to about here. So as you can see, we have the FVC, we have the FEV1 in that exhalation. Now, what you do start to see with obstructive diseases is the scooping out. When the sailboat doesn't look like it's out on a calm day, it's out on a windy day, or it starts to look like a fin, like a shark fin. That's what we mean by scooping out. So just looking at that, if someone had a tracing that looked like that purple line, you're already thinking this is obstructive disease. I don't know if it's cystic fibrosis or bronchiectasis or asthma, but I know it's an obstructive disease because nothing else looks like that. And you can see here, again, that whether you're using the flow volume loop on the left or the volume curve on the right, that you're getting some abnormalities. So everyone jumps right to the FEV1, but you really are supposed to start looking first at the ratio. You want to see how much of the entire breath out is blown in the first second. And I told you that's the only one that is age dependent. Here's another chart you have to memorize. Good Lord. The FEV1s are all 80%, but you see that the ratios are different for children aged 5 to 11 and those who are 12 and older. And then once you know what their FEV1 is and what the ratio is, then you can determine if they're intermittent, mild persistent, moderate persistent, or severe persistent. You with me? All right. So the forced vital capacity, maximum exhalation after maximum inhalation with the substitution of the FEV3 or the 6, And here's, again, to show you, in red is the FEC. It's the only number you can kind of guesstimate looking at a graph. The FEC on this individual is about 3.3 liters. Can you see that? The FEV1 on this tracing has a spike to show you where it is. My spirometer doesn't have this. And you want to make certain there's no coughing before you see that spike, or until you get to about that point in that downward sloping sail. And the substitution of the FEV3 or 6 if you can't get the entire exhalation. So in addition to that, at least 6-second exhalation, you also want to make certain that there's a plateau, that some people have leveled off on their exhalation, which is easiest to see either in a volume time curve or a forced expiratory graph. Again, repeating the FEV1, the amount of air that comes out in the first second of your maximum exhalation with that little spiky thing. And as you can see, the FEV1 is always expected to be more than 80%, but it becomes abnormal as you move by age into either the moderate persistent or moderate persistent for children and for those age 12 and older. So how do you know that you've got a good test? Because garbage in, garbage out. You want to get good data in so you have good data out. So you have to have an upward spike that peaks and a nice sloping sail without any coughing in that first second. So you have to have that in order for it to be interpretable. You might also see some other problems. You stop the test too early, Valsalva, when you kind of bear down. You'll never see that on spirometry. You got to look or sound. If someone makes a grunting sound when they're doing spirometry, you might not see any abnormalities on the tracing, but it's not good technique. So you can't let them do that kind of bodybuilder grunting. That's a Valsalva maneuver. You don't want to see that they're leaking any air out of the sides of their mouth or out of their nose. They might need a nose clip. That they haven't stuck their tongue in the middle of the mouthpiece. And they haven't stopped and taken an extra breath. So let's see what some bad techniques. Look at that on the left-hand side. Does it look like a sailboat on the left-hand side? When you start to see something that looks like a camel's back or VTAC, every time you see that, it's an extra breath that someone's taken. This is a single exhalation. We need that for them to blow out for as long as possible and have a flattening to the plateau. But as I said before, in children under 10, at least a 3-second exhalation with a 1-second plateau. And for those over the age of 10, 6 seconds for an exhalation with at least a 1-second plateau. So that's just kind of looking at some of the general values, and we'll apply that in the case in just a minute. So what are the things before we get to actually applying this information? I said that in order for you to get reimbursement, you have to calibrate it every day that you use it. You don't have to do it, you don't have to calibrate it if you're not using it that day. And that's to let you know, using a 3-liter syringe, that when you pump 3 liters of air through the spirometer, it reads it as 3 liters. Otherwise, and a lot of companies are saying, it was calibrated in the factory, you never need to do it again. That may be fine, but you really aren't supposed to get reimbursed for spirometry if you're not keeping a calibration log. You cannot prove that there isn't any drift away from that 3 liters. So you're supposed to have a printout of the graphic design, the sailboat, the numbers that you care about, the FEV1, the FEC, the ratio, and a calibration log. And you have to make certain that your patient is prepared to do the test. They need to be sitting because it can cause dizziness. And because it can cause dizziness, some people pass out. Sitting in a chair with arms is better than these kind of chairs without arms. To prevent leaking from the nose, you can use nose clips. If you have individuals who have a whole lot of truncal obesity and you think that they can't drop their diaphragm down, you might want to stand them up, but make certain that the chair is right behind them and you're holding on to them when they're doing the maneuver. And if you're going to do them standing, you keep them standing for each subsequent test. And you have to make certain that you have the right age in, the right sex in. The whole race correction is pretty controversial right now, but the recommendations are that you need to compare your patients to other people who look like your patients. So in the past, ATS, Knudsen, Crapo, they were all full of white people, white men. And our patients, and we don't look like that anymore. So for racially, ethnically diverse populations, NHANES has the most minorities and is recommended as your reference parameters for those over the age of 8 and Wang for those under the age of 8. You have to have the right height. No one knows how tall they are. Take their shoes off and measure them against with a stadiometer where you're actually getting good measurements against a wall. And then make certain that they understand the test demonstrated, and then you have to coach. So you take a deep breath in, and then I want you to blow it out. So deep breath in, blow, 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 squeeze, 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 keep going, keep going, keep going, keep going, a little bit more, a little bit more, a little bit more, a little more, keep going, 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 deep breath in. And the test. I've done a few of these. I was just texting over there. I need to borrow my spirometer, and I'm moving it around, and I'm trying to coordinate where my spirometer is and where I need it to be. By ATS criteria, you can only do 8 attempts. And you may want to stop earlier than that if they're dizzy or they're going to hit you. So for the correct technique, you want to watch that they first deeply, fully inspire, and then exhale. Go, 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 go. And that's fine. Those coughs at the end are fine. At least 6 seconds, and no cough in the first second. Unacceptable, they don't fully inspire. Unacceptable, they don't give you maximum effort. They don't blow out long enough. They cough in the first second. They stick their tongue or their gum gets put in the mouthpiece. They don't get the nice peak at the top, and there's too much variability between. So what do we mean by that reproducibility? How do you get those 3 colors to line up perfectly on top of one another? The largest and second largest FEC and FEV1 should be no different than 150 cc's, and they don't have to be from the same maneuver. So how do we know that someone's got a positive bronchodilator response? Right, this is it from the ATS. They have to have an improvement of at least 200 cc's and a 12% change after you give them albuterol. So in order to make certain that happens, you have to hold medications that might bronchodilate them. So hold SABAs for 4 hours, LABAs, theophylline for 12 hours. Exercise bronchodilates you, so no exercise for 4 hours prior to testing. Smoking bronchoconstricts you, so no smoking for an hour before. And how do you do it? 4 puffs of albuterol through a valve holding chamber, administered 30 seconds between puffs, wait 15 minutes, and then you do the bronchodilator testing. So let's take all of this and pull it together in this 30-year-old man who comes in with increased asthma symptoms during the spring season. He's got seasonal allergies, he's a non-smoker, but he has a frequent cough. So the first thing you want to do is not go to the FEV1, you want to go to the ratio. The ratio is age specific. He is 30 years old. So if you look at, and you want to use in this column the predicted for him. He's predicted to be 83%. You don't want to use a percent of a percent. So you're not going to look at what his percent predicted was. He was predicted to be 83. What did he actually perform? At a 69. What do we know about? He's in that 20 to 39-year-old. A normal ratio should be 80%. His is 69%. All right, so where does that fall? His ratio is reduced by more than 5%. It's 11% difference between 69 and 80. He's severe persistent. Do you see how we got there? Are you okay? You look confused.
Yeah, I was just working it out.
Okay, but we're good, right?
Yeah.
Okay. Now, you're going to go back to the other numbers. Is the FEC over 80%? Is the FEV1 greater than 80%? And did he have a positive bronchodilator response? And so if you're seeing obstructive disease, you're looking in the far left column, his FEV1 would be decreased, and his FEC could be decreased or normal. So this is what he would have maybe shown as his pre-bronchodilator in the green and his post-bronchodilator in the blue. And then this is really an algorithm. Oh, what's missing up there? Do you see up here you're missing? Can you read that on your slides? This should say no. Right there. See where I'm circling?
No.
Oh, man.
You gotta point up the top one?
Yeah, the cursor.
That cursor doesn't work.
No.
Right up there?
It says no.
Up there, that says no.
No, yes.
And up there, it says yes.
Oh, yeah, it's on here.
It's hard to read.
Oh, it's on ours.
It's on ours.
You got it? And you can read it okay? So remember, his ratio was low, it was 69%. So we're already thinking he's obstructive. His FEC, we've got to find out if it's low. If it is low, we're going to be thinking that he has some kind of an obstructive disease. If it is, if it's normal or high, if it's normal, yes. It can also be normal. This will take you down to do the reversibility testing to determine whether or not this is asthma or one of the other obstructive diseases. If the ratio is normal or high at the top, then it's either going to be normal testing or a restrictive lung disease. So you can kind of use this algorithm to figure out, is it likely an obstructive disease on the left, or if it's on the right, it's normal or restrictive, and it all starts with the ratio. His ratio is 69%, it was supposed to be 83%, so it is abnormal. Now we look at his numbers, and now we're going to see that his pre-bronchodilator, FEV1, was supposed to be 4.5. It was 3.5 or 77%. What is it supposed to be? 80. So you can circle that and say that's abnormally low. His FEC was supposed to be 5.4. It was 5.5. It should be at least, what number?
No, you mean 5.1.
5.4. All right, let me start again. The FEV1 and the FEC for everyone, no matter what their age, is supposed to be at least 80%. So, I keep on trying to show this to you here, and it's not. So FEV1, you see that line, second row? He was supposed to be 4.5, but he was 3.5. That's 77%. What should he be? At least 80. So this is abnormally low. His FEC, 5.48 was predicted. He did 5.15. What number do you want to see at least? 80. He is 94. So we see that he's had an abnormally low FEV1 over FEC, 69%. We see that he is an abnormally low FEV1, but a normal FEC. How can that be? Because when you give someone all the time in the world to blow out, they can get their air out. They have an obstructive lung disease. They just can't get it out quickly. That's why you have an obstructive disease. So now you compare the FEV1 pre 3.5 to post 4.00 after you've given them albuterol. Do you see that second row?
Yeah.
So he got better by 14%. What is the number you need to have a positive bronchodilator? 12%. And 200 cc's. Did he get 200 cc's better? How do you know? 3.5 liters is 3,500 cc's. He was 3,500 cc's before, 4,000 cc's afterwards, so that's 500 cc's. Ah, I just saw that. Like you just had an epiphany right in front of me. All right, and I'm not going to belabor. We talked about why we aren't big fans of pulse oxes, and there's some references. Did you get that?
Yeah.
Yes. Yes. Question.
FEV1 versus the 69% that he got. It says here to be severe, you have to be less than 60%. But he was 69%, so wouldn't he be?
But he was predicted, he was his, you have to look at what he's predicted.
Here.
It says 69.
He got 69%. The ratio is determined by whether or not you're more than reduced by more than 5%. So look at this slide here. He was supposed to be 80%. He was 69%. That's an 11% difference. Because it's more than 5%, he's severe persistent. Does that make sense?
Oh, I was looking at the whole number.
Yeah.
So if
Oh,
it's
that's
reduced by
FEV1.
5%, he's moderate, but if it's more than 5, he's
Yeah,
severe.
but that's,
Exactly.
you know, FEV1, but you gotta look at the ratio.
So the ratio is
The
the first
ratio.
thing. Remember that algorithm I
Yeah.
just showed you? That divides the world into normal, restrictive, or obstructive on the right-hand side. So if your ratio is low, you're obstructive. My brother has sarcoid. His ratio is normal. He's got a restrictive disease. He's on this
Hit the right.
right-hand side. Okay?
Maureen, I
Yes.
just do networking while you're up there.
Me?
Well, you were gonna do networking.
Am I?
Yeah.
What number is it?
Networking is 546.
And in the
The
book,
book is 272. And then I'm gonna do culture and
the case, and we're out of here.
yeah, so speed it up, girl.
All right.
272.
Are we ready? All right, so when we're talking about professional networking, referrals, and outcomes, we're really trying to talk about how we make certain that we're working as a team to coordinate care. We have to have documentation about what the patient understands about their asthma, their level of control, medication skills, environmental remediation, and their response to loss of asthma control. So you might want to develop some kind of approach where you're going to document and actually track of all of these things that you have to accomplish. Where are you? What is the level of the patient's being competent and having some knowledge and skills in these areas. So develop a site-specific education flow sheet where you document where they are, what concerns you have about their ability to integrate and understand this information, and then integrate it into a self-management action, coordinating this with all the other providers. That might require that you get on the phone and talk to people. It might also require continuing education to support the other healthcare professionals within the team and network, education in community settings, and having a relationship with the payers. So who is in this healthcare team you need to be really thinking about networking with? Your local pharmacists, the people in your schools, the people who are working in the acute care setting. And you want to identify community resources so that we really know what groups are available to support the individual, provide asthma education, provide some financial resources, and make certain that you have credible sources available for the individual. And then this collaboration has to occur across the entire spectrum of these other providers. So an asthma specialist is part of that, who's usually seen as a trained allergist or pulmonologist, or those who've developed specific expertise in the area. When do you refer to an asthma specialist? This comes right from the EPR3, when someone has had a life-threatening event. No matter what you do, they're not getting better. They have something that is atypical and makes you wonder whether or not they have a comorbidity or that they have something other than asthma. You might need to refer them to an asthma specialist because you need to do the allergy testing, to look up their nose and see if they have polyps, to do a complete set of pulmonary function tests, including testing for diffusing capacity or volumes that you can't do in an office setting. And remember I said that just because you have a normal spirometry doesn't rule out asthma. Asthma is a variable condition. In order to confirm the diagnosis, you might actually take them into the lab and provoke an asthma attack using methacholine under controlled laboratory conditions. You might have to send them out for allergy shots or for kind of advanced education if they have particular issues and barriers to adherence. So that asthma specialist, that referral should happen for anyone who has severe asthma. They're always on oral steroids or they're always on high-dose inhaled steroids. Or you think that there are kind of complication related to their occupational exposures. All children aged 0 to 4 with moderate persistent asthma should be seen by an asthma specialist. And any person, regardless of age, who is considered severe persistent, steps 4, 5, and 6, should see an asthma specialist. Or anyone that, despite what you're trying to do, doesn't seem to be getting better. Well, who else should the patient see? They might need to see mental health experts because they have anxiety, depression, they have financial issues, they have safety issues, because if you can't take care of those basic Maslow hierarchical needs, then you're not going to be able to manage your asthma or your child's asthma. So how do you know if you are providing effective quality care? So you need to figure out process parameters, which are what's happening within your workflow, and then what metrics are you using to determine whether or not your education and management is improving patient outcomes. So figure out who's doing what in your office, who has responsibilities, how you document it, how you track it, and then figure out whether or not what you're doing is resulting in improved asthma control. So some of the process parameter questions you might ask is there some kind of record kept of where the patient is in understanding the correct skills and demonstrating the right inhaler or device technique for what they've been prescribed? Are you documenting that the patient has myopersistent asthma, and that the medication reconciliation matches myopersistent disease. And did you, or how do you keep a record about how a patient is supposed to identify and respond to worsening signs of asthma, loss of asthma control? And there's lots of HEDIS measures. You know, your patient should be picking up more inhaled corticosteroids and less albuterol. And there are other ways that people identify asthma medication use. Is it the right medicine for this level of severity? Is the medication management for people with asthma appropriate? And this idea of an inhaled corticosteroid to SABA ratio, so that you're getting more inhaled corticosteroids and less of the short-acting beta-2 agonists. So there are their workflow practice things, and then there are external HEDIS measures that are also evaluating whether or not you're doing what you need to do in your practice, matching the patient, the disease severity, and the meds, so that you get that right ratio at the end. And then you've got to figure out, has what you've been doing working? Outcomes research evaluates your education by looking at patient outcomes before and after your teaching. So you might want to compare whether or not there's been a reduction in absenteeism, ED visits, hospitalizations, an increase in routine office visits, a decrease in emergent office visits, and whether or not you're seeing changes in pharmacy refill or pulmonary function test or symptom burden when the patient comes in. And then there's quality of life issues. That worry index improves, so they're sleeping through the night, they're using less albuterol, they're able to participate more fully in sports and activities. But you have to recognize that there are confounders to you getting the outcomes that you want. You have someone who's so severe and they're not taking their medications. You have patients who don't believe in biomedical model, they want to do herbs. They come from a group individuals in which they don't believe that asthma is a chronic disease but just episodic because of their cultural orientation. They don't have the money for the co-pays. They don't have, in fact, a teenager whose friends are telling them that, you know, they need to get off this medicine, that they actually have peer norm influences that don't support them. All of these things really are issues that we've talked about that may mean that your education and your workflow and your documentation may be perfect, but if you're not seeing the patient outcomes that you want, you have to go back and reconsider what are these barriers. Maybe the patient's just not able to do the things that you wanted to, and you have to reevaluate the plan. So provider barriers to getting the outcomes you want is a provider who has poor patient rapport. They don't give them enough time, they don't speak in plain living room language, they have problems with differences of languages spoken. They don't give feedback to the patient that your asthma's uncontrolled. We need to tell patients that I'm concerned about you, I'm glad you're here today because your asthma's out of control. They get interrupted frequently, and patients, by the time that they finally get in, if they've waited for an hour, that the patient wants to get out the door. They've got a foot out of the door rather than the provider having a foot out the door. So think about how you're going to collect your outcomes. You might want to do a review of your charts, or if you're working in a community setting, maybe school absenteeism records. Then you would do your intervention. Maybe you want to first look at what the pharmacy data is and how often are they refilling their inhaled corticosteroids. So you get your baseline before you do your teaching. And then after your teaching, you want to then follow up on these things immediately after the teaching and then more long-term, 6 weeks to several months or a year later, to see whether or not they've been able to move that into their long-term memory and make behavioral changes. You then compare your data, and you can actually submit this as an abstract at conferences. If it's a quality assurance, a QI, QA project, you may be able to have that presented or published. So in thinking about this, choose your patients carefully. You want them to have the disease that you're focused on and that they can make the changes that you want them to make. And you want to make certain that you have them see the same provider, not only for their outcomes, because you also understand that it's going to be important for their own personal disease control. So you do the education every day. You need to start to evaluate it, and you need to then evaluate and make changes, and share that information with others so that they can learn and we don't have to reinvent the wheel. Good? All right.
Yeah, well, I can do quick.
You doing culture?
I'm doing culture, but that's gonna be real quick.
All right.
But I want you to look at page 92. 'Cause
Slide.
Slide,
Culture is right after it.
No, there's another case.
Oh, crap.
473, slide. But wait a minute, I want you to look at 92, because I just want to be sure, because I mentioned this with peak flow, that you can put it, and you should put it on your asthma action plan. Page 92, that bottom slide tells you what your percentages should be of your peak flow best, and then what would be the green, yellow, and red zones. Don't expect your families to be able to do the math. You need to do the math for them so they can put it on their asthma action plan. Okay. So, and so we're going to do culture like in